Today's discussion will be on the pharynx. The pharynx is situated posterior to the nasal, oral, and laryngeal cavities. Thus, there's a nasopharynx, an oropharynx, and a laryngopharynx. It sits below the sphenoid bone and occipital bone and above the cricoid cartilage. Here is the cricoid cartilage right here. So it extends down to this level, which corresponds to roughly the C6 vertebral level. After which it becomes continuous with the esophagus. So that's what this E designates. The pharynx is generally a fibromuscular tube lined by a mucous membrane. It is the common channel for swallowing and for respiration, and the food and airway pathways cross each other in the pharynx. The nasopharynx, at least in its anterior part, may be regarded as the posterior portion of the nasal cavity, with which it has a common function as part of the respiratory system. The nasopharynx communicates with the oropharynx through the pharyngeal isthmus, which is bounded by the soft palate, the palatopharyngeal arches, and the posterior wall of the pharynx. The isthmus is closed by muscular action during swallowing. The choana are the junction between the nasopharynx and the nasal cavity proper. So this is the general location of the choana. We'll see that in a different view in another slide. The oropharynx extends inferior from the soft palate to the superior border of the epiglottis. So here we see that general demarcation. Keep in mind that the borders of the nasopharynx and the oropharynx, and then the oropharynx to the laryngopharynx, they're blurred borders. There isn't a well-defined transition from one to the next. This transitional area between the oral cavity and the oropharynx is characterized by a lymphatic ring of several tonsils, which we'll discuss in more detail later. The mucous membrane of the epiglottis, here's the epiglottis, the mucous membrane of that epiglottis is continuous or is reflected onto the base of the tongue and onto the lateral wall, which is hard to draw in here, but on the lateral wall of the pharynx. The space on either side of the median glossoepiglottic fold, let's just say that that blue line is that glossoepiglottic fold. There's a space on either side, and those spaces are called the epiglottic vallecula. Vallecula is spelled like that, and I believe the plural will add an E on the end. So there's two epiglottic valleculae, one on either side of that median fold. The laryngopharynx extends from the superior border of the epiglottis, which you might imagine is a moving border, to the inferior border of the cricoid cartilage. Again, here's that cricoid cartilage. Put a little C in there, where it becomes continuous with the esophagus. Its anterior aspect has the inlet of the larynx and the posterior aspects of the arytenoid and cricoid cartilages. So here we can make out those cricoid cartilages. We have that laryngeal inlet in that direction where air should pass. Hopefully it's just air. And then we have some arytenoid cartilages as well, which we'll kind of designate with these areas here. They're covered with mucosa. The piriform recess, in which foreign bodies may become lodged, is part of the cavity of the laryngopharynx, situated on each side of the larynx. Those piriform recesses are also hard to appreciate in this picture, and we'll see those in a minute. The hard palate and the soft palate separate the nasal cavity from the oral cavity. The nasal cavity again transitions into the nasopharynx via the openings called the choanae, and the narrowing of the back of the oral cavity by way of the fauces, these two faucial pillars, transitions the oral cavity into the oropharynx. So it's important to understand how all these areas communicate with one another. So obviously, if you inhale air through your nasal cavity, the air will go down into your nasopharynx, into your oropharynx, down into your laryngeal inlet, and down ultimately into your trachea. Obviously, if you breathe in some air through your oral cavity, it's going to go into your oropharynx and then again into your laryngeal inlet and down into your trachea. Now, if you drink some water, that water should be destined down here for your esophagus. So it's going to go again through your oral cavity into your oropharynx, into your laryngopharynx, and then into your esophagus. So that seems relatively basic and easy to understand. Well, normally when we swallow, we have our soft palate here, which flips up. We'll talk about that a little bit more. And it closes off your oropharynx from your nasopharynx so that liquids don't normally go up in that direction. But I would get Dr. Williams very distraught if I didn't share with you the sometimes how these this mechanism fails. So imagine you're on a date and you decide to have a glass of wine on your date, and you drink that wine, and you would really like for that wine to go into your esophagus, obviously, especially if it's red wine. But you have your date who's with you, and you take a swig of that wine, and the soft palate for some reason does not close. You might end up having a situation, as Dr. Williams did, where that wine comes out your nasal cavity and spritzes the white shirt that your date is wearing. So this is an unfortunate event, but perhaps in the long run, very fortuitous, because I believe he married that young lady and is still happily married to this day. Okay, so let's switch gears ever so slightly and talk about the muscles of the pharynx. So in the discussion today, we're going to have a total of 8 muscles. We're going to have 3 constrictor muscles. We're going to have 3 long, thin strap muscles, and then we'll have 2 palatal muscles, specifically soft palate muscles. The primary purpose in which the muscles of the pharynx combine their action is for swallowing, a very complicated neuromuscular act where the food is transferred from the mouth through the pharynx, through the esophagus to the stomach. The pharyngeal stage is the most rapid and the most complex phase of swallowing. So once again, there are 3 overlapping constrictor muscles, the superior, middle, and inferior pharyngeal constrictor. Their overlapping has been compared to that of 3 flower pots placed inside one another. They form the back of the pharynx. While the right and left sides of the muscles connect in the back, they would be connecting right here. They are open in the front, and therefore the muscles are not completely circular. As you can see here, all the pharyngeal muscles are innervated by cranial nerve 10, or the vagus nerve. The superior pharyngeal constrictor attaches onto the pterygomandibular raphe, the hamulus of the medial pterygoid, and the pharyngeal tubercle of the basilar portion of the occipital bone. Of course, the right and left merge into the pharyngeal raphe, which we see in this area. The middle pharyngeal constrictor attaches to the stylohyoid ligament, the lesser and greater cornu of the hyoid bone, and at midline into this midline raphe, pharyngeal raphe. The inferior pharyngeal constrictor has a rather broad attachment here into the thyroid cartilage, the cricoid cartilage, and of course again into this midline pharyngeal raphe. So I realize when we look at these pharyngeal constrictors in their isolation in images like these, it's pretty hard to understand how they relate to other structures. So here we see that hard and soft palate coming in. You can see that superior constrictor, at least the uppermost portion, at about the level of that hard and soft palate. Of course, if we put a tongue in, we can appreciate where the superior constrictor and middle constrictor is in relationship to that tongue. So of course we would have that transition from the oral cavity into the oropharynx at this level, somewhere between the superior and middle constrictors. Of course we have the esophagus that's going to be extending down from within the boundaries of the inferior constrictor after the laryngeal inlet. So here's what we might see in lab, where we have this posterior view of the pharynx. So the head has been dropped forward, and certainly we can make out the carotid. We can make out a internal jugular, and we can make out a sympathetic trunk here, and probably a vagus nerve right there. And of course we have this pharyngeal raphe down the middle. It's much more apparent. It's more superior than it is inferior, but you can imagine that there is some fibrous connection between the right and left sides in that area. And of course we have the superior and middle and inferior constrictors, and as you can tell, it's there's not quite a clear boundary. What we're going to see in lab between the superior and middle is going to be a muscle. We just can't make it out right now. We're going to see a muscle here called the stylopharyngeal muscle coming in between the superior and inferior, and it gives us that demarcation between the two. Of course, posteriorly, we can really make out this transition of the inferior constrictor. So that helps us out. So we'll use this stylopharyngeal muscle to give us that demarcation between the two. So this is a rather neat picture. It's the same picture as we just previously saw. However, the pharynx, the posterior wall, or those constrictor muscles have been cut. So this is the free edge of the constrictor muscles, and this is also the free edge of the constrictor muscles. And so the pharynx has essentially been opened up, and we have the nasopharynx, or I'm sure we'll call that the nasal cavity here. And so this general area would be one choana and a second choana, and together those are choanae. And then here we have a tongue. And so way up in here, I'm just going to write a small O. That's the oral cavity inside of there anteriorly. So here's your tongue. Here's your epiglottis. And the epiglottis, the top of it's folded forward, so we can't see the very top of it. And so air would go into this tube here, and then food, or liquid, let's say, if it's swallowed, it would go to either side of the epiglottis. Okay. This would be the area of the piriform recess on one side and another piriform recess on the other. So again, here's the back of the tongue. Liquid would come down. Let me change the color. Liquid would come down to either side of the epiglottis into these piriform recesses, and then would continue down into the esophagus. Let's take a look on the left-hand side. So again, we have that as choanae. Now these little black lines are not really intended to point to these structures. Those are the tips of the turbinate bones, but rather it's pointing to these openings here. So those are choanae. And of course, this is the oral cavity. This is the back of the tongue. This is the back of the tongue. Here's the upper edge of your epiglottis. All right. And so again, fluid, now I'll color it in light blue. Fluid would come down into these piriform recesses and down into the epiglottis, while air, hopefully, would travel down that way. As a small note, we had talked about valleculae earlier. So again, let's go back. We have the tongue. So we have the tongue here, and there are some pits here, if you will, on either side, anterior to the epiglottis, but posterior to the tongue. That's where the valleculae would be. So let me write that in. We have a valleculae there, and then we have essentially the piriform recess there. In addition to the 3 constrictor muscles, there are 3 longitudinal elevators of the pharynx. All 3 of these muscles act to elevate and to assist in the closure of the oropharynx during swallowing. The stylopharyngeus muscle rises from the styloid process, passes inferiorly in between the superior and middle pharyngeal constrictors, and attaches onto the pharyngeal constrictors themselves. Stylopharyngeus is innervated by cranial nerve number 9. The palatopharyngeus muscle rises from the soft palate. It helps to form a fold of the same name, in other words, the palatopharyngeal fold. It extends inferiorly and posteriorly to attach onto the pharyngeal muscles and also onto the thyroid cartilage. It is innervated by cranial nerve 10. The salpingopharyngeus muscle arises from the eustachian tube and extends down to insert onto the pharyngeal muscles. It helps to elevate the pharyngeal muscles, but in reverse action can pull down and help to open the eustachian tube. Salpingopharyngeus muscles innervated by cranial nerve 10. So in review, we have the salpingopharyngeus and the palatopharyngeus innervated by 10, and the stylopharyngeus innervated by 9, along with the 3 the constrictor muscles innervated by 10 as well. So in review, all 3 of these longitudinal muscles act to elevate the pharynx, but as this diagram depicts, the stylopharyngeus, shown here in number 5, which originates from the styloid process, because it emanates from this process which is both superior and lateral to its insertion point, it has the ability to pull upwards and laterally, or to widen the lumen of the pharynx if needed. Here we can see the posterior pharynx as well, or at least a posterior view of it. And again, the constrictors have been cut in this view. But we get a nice view of the stylopharyngeal muscle. And as we said before, it extends in between the superior and the middle constrictor. So we can see that here in this view. We could also possibly see it when the pharynx is not cut. However, we have to do some extensive dissection in and around that stylopharyngeus. What's nice here, you can also see the glossopharyngeal nerve coming down and having a very close, if not close proximity, if not sitting right on that stylopharyngeal muscle distally, as that muscle extends distally down towards the constrictors. Just like the pharynx has several elevators, so does the soft palate. So in this picture, we see the hard palate extending into the soft palate, and you can see this downward movement. Well, once again, this soft palate can be brought upwards in that direction to help kind of extend this palate posteriorly. To do that, we have a pretty complex mechanism, really driven by two structures, the levator villi palatini and the tensor villi palatini. And as you might imagine, the levator helps to really do the elevation, and the tensor helps to tense the palate. So here we see those two muscles in a different view. This is looking from the posterior side. We can see the tensor villi palatini. It's situated very vertical. Now this doesn't make much sense. You would think the levator is situated more vertical than the tensor. So we have this tensor villi palatini more vertical, and on the other side we have this tensor villi palatini, and it's going to send a tendon across, and this one will send a tendon across. And as you can imagine, if it contracts upward that way and upward that way, that the sheet of tissue that it's attaching to will help to broaden or flatten out. So that's why it's called the tensor villi palatini. Conversely, we have a levator villi palatini going a little bit more obliquely, but there is a direct pull of this levator villi palatini on the soft palate. I guess I should have said that this here is the soft palate. All of this is the soft palate. And here we see the uvula. And so the levator villi palatini is going to pull up and out, but really bring these tissues. This one's cut on this side, but it's going to come that way. And so here we have the mechanism of how the levator villi palatini pulls generally upward, especially a bilateral contraction. And with a bilateral contraction of the tensor villi palatini, we have this broadening. So again, we really want this to happen during swallowing, where we want the uvula to go posteriorly and upward and press up against the posterior aspect of the pharyngeal wall. So basically up against those constrictor muscles. So to get that done, we need a little bit of tensing and we need a little bit of elevation for that to happen. So it's important to note here that the tensor villi palatini is innervated by cranial nerve 5, and the levator villi palatini is innervated by cranial nerve 10. And to help me remember which is which, tensor has T-E-N-S-E, it tenses, and that's 5 letters. And then the levator must be the other. Also, note that the tensor villi palatini starts with a T, and so does trigeminal. That helps out as well. So this basic diagram just gives you a different idea. Here we're looking at a side profile of the soft palate where it's angled down at rest. We need to get that soft palate up so that the uvula, which is here, needs to get up that way. So to do that, we have that elevation of the soft palate where the uvula now is in contact with the posterior pharyngeal wall. And here's another nice dissection of this where we have the soft palate here. We have the uvula that's going to be hanging down. And we have the levator on both sides coming in this direction, pulling up. And a little bit obscured here. It's not fully dissected out, but it would be back in this area. And then we have the tensor that's going to be pulling outward on that soft palate. So just a very quick review. We have 3 constrictor muscles, all innervated by cranial nerve 10 or the vagus nerve, and the other 2 of the 3 longitudinal muscles, vertical muscles that elevate, innervated by cranial nerve number 10 as well. Of course, we have that outlier, the stylopharyngeus, innervated by glossopharyngeal nerve or cranial nerve 9. And then we have the tensor, innervated by trigeminal. And then we have cranial nerve number 10 as well, innervating the levator. So now let's switch gears a little bit again and talk about some of the special features or special structures that we'll see within the pharynx. Earlier we discussed the salpingopharyngeal muscle that emanates from the eustachian tube in this area and pulls down to open the eustachian tube. So this eustachian tube or auditory tube, or also called the pharyngotympanic tube, connects the nasopharynx to the tympanic cavity. Now that tympanic cavity is in the middle ear, so we're connecting the middle ear into the pharynx, if you will. So you could imagine that if there's an infection in this area, that it could go up into that tube and cause an infection in the middle ear. So that's generally the mechanism for that middle ear infection that we know, especially in the younger population. The eustachian tube is really responsible for equalizing the pressure of the external ear and the pressure within the middle ear. This tube is about 3 to 4 centimeters in length. It extends posteriorly, laterally, and superiorly. The eustachian tube has two primary components. It has a cartilaginous part, which we see here in the pharynx, and then more closer to the temporal bone in the middle ear, we have a osseous component. So we'll put an O in this area, and we'll put a C for cartilage in this area. The very end, which is where we'll see this within the pharynx in gross lab, there's the cartilage kind of showing itself in this area. And that section is called the torus tubarius. There are three primary sets of tonsils. A tonsil, as you may recall, is a mass of lymphoid tissue containing reaction or germinal centers. The pharyngeal tonsil is embedded in the mucous membrane of the posterior wall of the nasopharynx. And large pharyngeal tonsils are termed adenoids and may cause respiratory obstruction. Each lateral wall of the oropharynx has the diverging palatoglossal and palatopharyngeal arches. Here we can see that somewhat in this picture. So these produce the anterior and posterior pillars of the fauces, which help to form the posterior aspect of the oral cavity. The triangular recess between the two arches lodges the palatine tonsil. So let's draw that in blue. The palatine tonsil would be right there in between the two. So if you hear the term tonsil, generally the person is likely referring to this palatine tonsil. Lastly, on the posterior surface of the tongue lies the lingual tonsils. So this would be the general area for the lingual tonsils. In this illustration, we see an anterior view of the oral cavity. In this view, we can see a few arches on the back of the mouth. Here we see an anterior arch, and behind that we'll see a posterior arch. The anterior arch is formed by the palatoglossal muscle, which helps to form the palatoglossal fold. In other words, the palatoglossus muscle is in the palatoglossal fold. And then posteriorly, the posterior pillar or the posterior fossa is formed by the palatopharyngeus muscle, which helps to form the palatopharyngeal fold. In between these two folds, we have that palatine tonsil resting right up in there, and we can hopefully make that in lab. These involute over time, especially after adolescence, and so we may not be able to see a very prominent tonsil in that area. Certainly these are problematic in young children, and so if someone's going to be having their tonsils removed because they can be quite enlarged, we're usually referring to these palatine tonsils. So on the left here, we have a nice view of the palatoglossal fold, and we can see behind it, I'll draw it in green, we can see the palatopharyngeal fold back here. And then in between the two, of course, we have the palatine tonsil in there. We have one on this side as well. And then over on the right, we can see ones that are quite enlarged, and as you can imagine, the airway is becoming constricted here, and these can be quite uncomfortable as well. So this large structure are these inflamed palatine tonsils. The motor and most of the sensory supply to the pharynx is by way of the pharyngeal plexus, which is situated chiefly on the middle pharyngeal constrictor and is formed by the pharyngeal branches of the vagus and glossopharyngeal nerve. Motor component is supplied by the vagus to all the muscles except for stylopharyngeus and, of course, the tensor veli palatini, which is supplied by cranial nerve 5. The sensory fibers in the plexus are from the glossopharyngeal nerve, and they supply the greater portion of all three parts of the pharynx. So we'll write in sensory here, plus one motor component. The arterial supply to the pharynx comes by way of three vessels. The superior thyroid and ascending pharyngeal come off of the external carotid, while the inferior thyroid, as you may recall, comes off of the thyrocervical trunk. Blood from the pharynx drains primarily into two plexi. Superiorly, the pterygoid plexus drains ultimately into the internal jugular, and the pharyngeal plexus drains ultimately into the internal jugular. So this concludes our discussion of the pharynx. Here we have some summary points that may help you with your studies.